Good evening. I would like to welcome you to tonight's virtual program, The Science of Candela EBD, Therapies in Regenerative and Preventative Medicine, moderated by Dr. Konika Schallen. If you have questions during today's event, please enter them in the Q&A box. We will answer as we go along. If you encounter any issues with the video or connection, please refresh your browser, as that will often fix minor issues. Google Chrome is the preferred browser. The information and photographs contained in this presentation are the property of Candela and its consulting healthcare providers and are provided for global training, education, and discussion purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws, or regulations that might apply to use and operation of these devices. For this reason, please review your country's current indication for use as provided by the respective regulatory agency. By sharing this information, neither Candela nor any of its consulting physicians give you the right to use the information presented, and this content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of the qualified licensed healthcare professional. Individual healing times, discomfort, treatment results, and satisfaction can vary. By participating in this webinar, you agree not to photograph, reproduce, or distribute any of the information or photographs presented during this webinar. With that, I am very pleased to introduce our moderator for this event, Dr. Konika Schallen. Dr. Schallen has over 20 years of medical experience with a focus on aesthetic and laser medicine, and serves as Candela's SVP of Clinical Operations and Medical Director, while also maintaining her aesthetic practice in Jacksonville, Florida.
Thanks very much, Grace. And on behalf of Candela, I'd like to welcome everybody to our presentation this evening. We have a distinguished group of panelists who I will introduce to you shortly. But before I do that, I want to remind everybody that we're here to talk about our energy-based devices and skin health. And many of you may have seen the most exciting bit of news coming out from the literature of ASLMS, the American Society for Lasers in Medicine and Surgery, this last weekend, and that involved the pulse dye laser, the V-beam, and its role in skin health with the reduction of 50% reduction of basal cell cancers out of the Mass General group. That is very exciting, completely also paired with Nordliss, and we'll talk a little bit more about that. So I'm going to start with Nordliss and talk about how Nordliss is certainly wonderful for vascular lesions, but also is very useful as a versatile platform. So fantastic as a platform because you can do so many different things that walk into the clinic, very useful, very practical, very much a medical device as well as a practical device to own in the clinic. The Nordliss selective wavelength technology has always been selective. It's the first to have been selective, and the selectivity is very important because it allows you as a practitioner to use only the amount of energy that's necessary to treat your target without having excess energy. And the wavelengths have been really concentrated to really treat those targets. So these are the variety of different applicators that are present to treat targets. There are hair removal applicators of many types, including for darker skin. There are vascular and pigmented lesion applicators. And then there are lasers, the Nd:YAG 1064 and two non-ablative fractional lasers, the 1940 and 1550 nanometer non-ablative fractional lasers. So it's a very versatile platform for a lot of use. There are both clinical cosmetic uses as well as medical uses. And of course, so many things fall in between. And as we talk about many of these conditions with our expert panelists, you'll see that there's a real use for energy-based devices in treatment of what is really seen here in the middle. Things that include inflammatory acne, things that include a variety of vascular lesions, and a variety of pigmented lesions. Now, one often thinks of energy-based devices as a aesthetic type of procedure or aesthetic type of device, but the paradigm is really shifting from aesthetics to true skin health and skin longevity. Aesthetics is really paired with skin health because healthy skin is beautiful skin. So the consumers are realizing that, and there's a growing interest now in terms of how to make skin look healthier naturally, and also how to maintain that benefit as we all want to look good as we age. Nordless is a fantastic device to meet that demand because it's very easy to combine a variety of treatments that address these immediate skin concerns like pigment or vasculature or some immediate wrinkles, but also promote good skin health and long-term benefit to the skin. It has a very wide appeal, not just for cosmetic and medical patients, but for patients that are interested in proactive skin health. What I'd like to share is something we've shared at IMCAS and also at the ASLMS meeting, and that is a little bit about non-ablative fractional laser and its proven role in skin structure and skin health. We know that non-ablative fractional laser upregulates expression of collagen-related synthesis genes, and it downregulates the matrix protein production. We know that it modulates cell proliferation and it affects coagulation processes. What does that mean? Well, it enhances skin quality as a result. You have good dermal remodeling that leads to dermal thickening and a nice, healthy collagen layer. As a result, you get improvements in texture. As a result of decreased keratinocyte differentiation, you get a reduction in pigmentation and truly a prophylaxis of keratinocyte-related cancers, which have been shown both by retrospective studies in patient populations out of Harvard, as well as our prospective study, which involved epigenetics in the skin. We recently did a study out of Candela that tested just the non-ablative fractional laser, and we chose only the 1940 wavelength because it's a very well-tolerated wavelength, a single wavelength that can be used across skin types and all year round. And what we found after we did a series of 3 treatments is that this one simple wavelength significantly modulates DNA methylation, and it influences the gene expression in a variety of pathways. We found over 180 genes that were related to skin, and in 3 separate buckets: the cosmetic bucket, the cell aging bucket, and also the skin cancer bucket. And we found that genes that were associated with these were initially upregulated or downregulated, depending on the benefit, at 1 month after we did the treatments. But we found a longer lasting benefit that was maintained even after 6 months after the final treatment. So the longer lasting results show that genes associated with the pigmentation, skin homeostasis, chromatin remodeling, structure and barrier function, wound healing, and skin regeneration were maintained. And most importantly, that keratinocyte differentiation was stopped for 6 months post-treatment, and cell senescence was also stopped in these genes related to skin. So that was some very exciting news that I wanted to share to you that's specific to Nordless, and that also combines with what we know about pulsed dye laser. And with that, I want to turn it over to our panel of speakers that we're delighted to have join us here today. Dr. Cordula Ahnhudt-Franke, who's based in Mallorca, Spain, Professor Faraz Al-Niami out of the UK, Dr. Nicola Dermac, who is out of Italy, and Dr. Didac Barco out of Barcelona, Spain. And this group has so much experience and many publications and so much experience combining our lasers and other energy-based devices. And what we're here to talk about specifically are those interesting things that focus on the health of the skin with Candela EBD. I'm going to turn it over first to you, Cordula.
Thank you so much, Konika. Good evening, my dear colleagues. Greetings from Mallorca, from this sunny island. And as you can imagine, we are facing lots of patients with UV skin damage. This is the most common condition actually treated by dermatologists in Western countries. And the number is rising dramatically. So we have a prevalence of up to 60% in light-skinned individuals over the age of 60 years. So this is something that we are really facing daily in our practice, and we have to diagnose it properly, and we also have to treat it properly. Yeah. So what are the effects of UV irradiation on the skin? There are some good effects, some positive effects, of course. I mean, we have vitamin D synthesis, we have mood boost, we use UV light in skin treatments, but there's also lots of negative effects, as we know. One of them is the photoaging process. So we have an increased MMP activity, which leads to a degeneration of collagen and elastin. We see immune suppression. We have ROS formation, which leads to cellular apoptosis and inflammation. And we have the big challenge of photocarcinogenesis with DNA damage and genetic mutations that we are facing. So UV light is the #1 cause of skin cancer, and this is something we really need to be aware of, and we have to talk to our patients about this, especially when we are performing anti-aging treatments. You know, the protection from UV light has to be one major precaution, you know, in the treatment that we do. Yeah, so diagnosis is super important. We need to identify them, all damages, even in early stages. We see lots of patients in our clinic who've been to aesthetic clinics, and you know, and I think it's important to invest in good diagnostic tools. There are very good video microscopic tools today that help us to diagnose and to monitor actinic changes and skin cancers. So let's quickly go through the actinic keratosis. I'm sure you are very aware of it. These are early stages of SCCs, of squamous cell carcinomas. We see them on all the sun terraces of our skin, so mainly on the face, on décolletage, on the hands, and on the scalp. Don't forget the ears as well. So they can appear as rough or scaly patches of different colors. Some of them might itch or burn or feel tender. Others are totally asymptomatic. And of course, they increase with the aging population and with sun exposure. And we have to understand that this is a chronic progressive disease. They will worsen if left untreated. So part of our treatment has to address them. Field cancerization is also a diagnosis that we have to make, unfortunately, in lots of our patients. So which means we have visible and subclinical keratinocyte dysplasia at the same time. And the field cancerization, or the stage of field cancerization, is a biomarker of sun damage. And this can actually help to predict the progression risk to invasive SCC. Here you have several samples of actinic keratosis, so of quite severe photo-damaged skin. Some of them you can't really see well on pictures, but you can usually palpate them well. Yes, so these are always the first sign. Some of the AKs can develop into invasive SCCs, so squamous cell carcinoma, which means atypical keratinocytes break through the basal membrane. They can either arise from de novo or from pre-existing actinic keratosis. They are about 20 times more common than malignant melanoma. Yeah, and there's only one treatment option, which is the excision, of course. And the other most common skin cancer is basal cell carcinoma, which represents between 80 and 99% of non-melanoma skin cancers. They seem to arise from basal keratinocyte stem cells, which just had an unregulated cell growth that leads to the tumor formation. There's different types of BCCs we see in the clinic, nodular or infiltrative BCCs. They need to be excised, But the big number of superficial BCCs, they are treated as actinic keratosis, and here come our lasers to use and lead to a really good aesthetic outcome. So that's one of the skin checks that we do on our patients. Here you see a very photo-aged body with rosé patch on the chest, and we have an AI-assisted system by photo finder, which helps us in diagnosing the lesion. Yeah, and you can see here that it's in the right in the red section, which means it's something that has to be removed and which is definitely not positive. So as a take-home message, AKs and non-melanoma skin cancer, they are chronic skin conditions. They require regular skin checks. So we do recommend annual skin checks to all of our patients. If they had AKs or NMSCs in the past, we see them every 6 months. And of course, the earlier you detect them and to manage them, the better is the outcome. So which treatment factors do we have to consider? Of course, there's some patient factors. This is the immune status, the age. Lots of patients that suffer from these actinic damage are already older. We have to see which treatment compliance they have. It also, of course, depends on the lesion factors. So where are they localized? What's the clinical features? How big are they? Which area is affected? And then we have treatment factors. So we differentiate between lesion or field-directed treatment. And of course, we have to discuss then the duration, the side effects, the equipment availability, and the cost for the treatments. So basically, there's 2 different treatments we have, or treatment, let's say, strategies. The first one is lesion-directed therapy, which means we only treat a single AK. The cryotherapy is probably very well known to you. I think, in my opinion, there's far better treatments than cryotherapy. So an ablative laser or a V-beam, for instance, leads to a much better aesthetic outcome than cryotherapy. But the gold standard should be the field-directed therapy, which treats not only the existing AKs, but also subclinical damage and minimizes the risk of SCC development. So here you can see a video where we were treating singular AKs using V-beam. Does it start? Can you see the video? No. Yes, now it starts. Yeah, so it's very straightforward. There's no local anesthesia needed. We used 7 millimeters with a very short pulse duration of 0.45 milliseconds and quite a low energy, DCD off. You receive a purpura of various intensity, and usually 1 session is sufficient to treat those areas. What we use a lot more is field-directed therapy. Here is, of course, photodynamic therapy, PDT, the most the gold standard. We've been using it in our clinic since 2002. Using a fractional CO2 laser as a preparation to increase the penetration rate of the photosensitizer. What we found is that not every patient is really liking this treatment. So it's quite painful. It can cause quite a lot of inflammation. So then we started to use the NFL 1940 instead, which is not ablative, as you know, but it also opens the epidermis. It leads to MENS and gives us a good penetration, so drug delivery, so to speak, of our photosensitizer. And the results are very nice, not only aesthetically, but we treat the actinic keratosis at the same time. Another combination I started to use more and more in the clinic is to use the V-beam for solitary actinic keratosis and then treating the whole area, for instance, a décolletage or a face with the 1940 to regenerate, to repair the actinic damage and to improve the texture of the skin and achieve a good aesthetic outcome. So here I'm going to show you a combination treatment containing, sorry, do you have to click this again? No, yeah, now we start. So first we treated actinic keratosis, solitary actinic keratosis, flat ones only, yeah, on the face with the PDL, again with 7 millimeters and 0.45 milliseconds DCD off. And then we treated the lentiginase for rejuvenation. We did 2 passes with the PR, and then followed by NAFL 1940 full face with a high coverage, so reaching 48% coverage, which you need 5 passes for, to achieve the good regeneration and glow of the skin. Yes, so what's the take-home message? Always aim for field-directed therapy when we see actinic damage. The goal is always to improve both actinic damage and the overall skin quality. And this is the homework that we give to all of our patients. This is our ABC Plus that they have to use at home. A stands for vitamin A, retinol, that boosts the cell turnover. B is vitamin B3, so niacin, which enhances the immune protection, and vitamin C as a strong antioxidant to protect the cells, followed by sunscreen SPF 50+. That should be the daily use. So now I want to share some clinical cases with you. This is a very old patient. He's already 97, so I can't really do PDTs every time he comes to the clinic because he's, you know, he's not that mobile anymore. So between PDTs, I usually treat his hyperplastic keratosis with V-beam. So first we reduce or we remove the keratosis and then treat them with V-beam in the settings that I told you before, which keeps it very good under control. That's a lady who had V-beam treatment done on an AK on her forehead, which did not work so well, so she didn't respond fully. We then did an NAFL 1940 full face with a high coverage and applied the photosensitizer on the AK and sent her outside into the daylight, which really showed a very good result, and she was very pleased with the overall improvement of the skin quality and of the texture. And that's another patient who has lots of actinic keratosis. So you can see them mainly here on the left cheek, but also on his forehead. He's been in the sun a lot in his life, so, and he wanted to look younger at the same time. We did a combination treatment here with PR 530, so IPL, yeah, then followed by 1940 with a high coverage again, and then applied the photosensitizer on the AKs and sent him into the daylight for 2 hours. And so we could treat all the things in one session with a really good outcome. So, yeah, my conclusion is the number of AKs and NMSCs will rise in the future. So we have to be prepared. We really need to focus on the in our treatments on the prevention and on the protection. We have to offer treatments to our patients that regenerate, that repair the UV damaged skin. We have to make them understand that field therapy is necessary in lots of cases, and that laser therapies can improve the not only the aesthetic aspect of the skin, but also the skin health. So regenerative aesthetics meets dermatology. So I think this is something that we need to combine to please our patients, and we have the perfect tools with the lasers and EBDs from Candela to do so. Thank you very much. Whenever you come to Mallorca, please feel free to visit us at mySkin. Thank you.
Thank you so much, Dr. Cordula. That was so interesting and so timely with all of our focus right now on skin cancer, and particularly that combination of V-beam plus 1940 is really, I think, very, very helpful for the patients long term. So thanks for sharing. Thank you for sharing that. And next up, we have Professor Firas, who is going to talk to us about non-ablative fractional lasers and cosmeceuticals.
Thank you very much, Dr. Konika. Well, good evening, everyone from sunny London. I believe today is as sunny as Mallorca. Very nice weather. Right, so really this non-ablative fractional laser handpiece in 1940 is a fantastic handpiece. I mean, it's a brilliant wavelength, it's very ergonomic, and we are just discovering more and more of its benefits. I mean, my colleagues already talked about skin cancer prevention, field cancerization treatment, actinic keratosis with Frax 1940, but also the epigenetic side of things. So what I want to address with this particular wavelength is also the ability to combine this with cosmeceuticals. We're very much living in regenerative health medicine era, and we're very much working with combination therapies. So the question is, how can we combine this particular handpiece with some of the cosmeceuticals, more for cosmeceutical delivery? Just to highlight the difference between this particular wavelength and the other wavelength, the 1550, which is the other non-ablative fractional laser handpiece that comes with the Nautilus. Now, even both of them are absorbed by water, but the absorption spectrum, the coefficient absorption spectrum for each of them with water is different. As a result, the 1940 is much more strongly absorbed by water, and therefore its effect is very superficial compared to the 1550, which is more dermal and deeper. So if we then just focus now on the non-ablative fractional laser 1940, because of its strong absorption by water and having most of its effect in the epidermis and dermis, and you can see this here from the graph with that blue line, that is the water absorption. So as you can see, it's not particularly linear, but as you get closer to 2000 nanometer, you have stronger water absorption. And this is why with the 1940, you have stronger water absorption compared to the 1550. And this is best seen really with histology results. So this is the histology from Candela. It's a study from Candela that was done. And if we look on the side of the 1940, you can clearly see that the effect is very superficial compared to the 1550. So you see the epidermal coagulation and in the papillary dermis. But what's very interesting, and my colleague already alluded to that, is we get this microscopic cracks, if we can describe it on men's, in the epidermis. So the skin remains intact after the treatment, and there is no oozing and crusting, and this is why it's still a non-ablative. But it's somewhere of a hybrid between an ablative and a non-ablative, with more of a microscopic ablation. And that allows us to bypass the barrier of absorption when it comes to cosmeceuticals, and enhances the absorption and the delivery of cosmeceuticals. So what does that mean? That means we are having to have a synergism between the benefits of the non-ablative fractional laser 1940, the switching off the cellular senescence, the epigenetics, the smoothing of the skin, but at the same time we are able to deliver molecules. Now, it's also important to just mention that this particular handpiece comes with different scanner widths, and this means that we can customize our treatments. And this becomes particularly important if we are using this handpiece for superficial scars or areas where we want to enhance the delivery of molecules. So for example, if we have a narrow scar, we can use a 4 or a 6 millimeter scanner width, whereas if we're treating a larger area, or let's say a full cheek, we can then use the 10 to 12 millimeter scanner width. And this is very good. This is an advantage that we have compared to many of the other devices that are available in the market, because we can customize the treatment using the right scanner width for the right area, and then deliver the molecules exactly where we want them to be delivered. Right. Okay, so this is just a video showing you the practical side of how easy it is to use this handpiece. Yeah, you can see the video is showing. And all you need to do is just hold the handpiece and glide it over the skin, and then we are having the columns of coagulation being scanned. This is an interface that shows us all the parameters that we can play with, really, and adjust. So where it says 10, that is the fluence, and you will see that the estimated depth of penetration is not deep. It's 170 micron, and that is because it's the 1940. If you want to go a bit deeper, we can increase the fluence, or we can decrease the fluence if we are in a very shallow area. But you can see that by getting to 170 micron, we are definitely able to then get the cosmeceuticals into the dermis we want, where we want it to be. Right, so this is one of my first patients who had the non-ablative fractional laser 1940, and you can see certainly clearly the multiple benefits that were already explained. It's not just improvements in the superficial pigment, but overall the quality of the skin. And by combining this handpiece with the cosmeceuticals, that we apply them immediately after the treatment, and for a few days afterwards, we are able to then have this synergism between the effects and the coagulation effects of the 1940 and the advantage of delivering the cosmeceuticals. So this could be things such as topical vitamin C, non-cross-linked hyaluronic acid. We are now very much into the era of regenerative medicine with exosomes, with PDRN, and certainly for some of the pigmentary disorders, things such as tranexamic acid is something that I use a lot. Right, so some other examples of patients where I combine the 1940 together with cosmeceuticals. So this is something that's quite close to my heart, and I have done a few studies on laser-assisted drug delivery, but in this particular case, we're talking more of cosmeceutical-assisted delivery, rather as in laser-assisted cosmeceutical delivery, rather than drug delivery, because really for drugs, you want to go deeper. So we have other modalities for it being more amenable to cosmeceuticals, really. This is just one of my studies that were performed many years ago, where we did a split phase study. But what it really showed is that the synergism between fractional lasers and cosmeceuticals, that 1 + 1 doesn't equal 2, but it equals 3. And I think this is the powerful message that I want to send across, is that by simply combining cosmeceuticals with the 1940, we are accelerating and enhancing the treatment of either of them when performed alone. So the initial data came from a comparable wavelength, the 1927, which showed the microscopic cracks in the epidermis, and really this channels that we have, which will allow for enhanced delivery. And recently, just very recently, there was a very elegant paper actually published by my co-speaker also, Dr. Konika Patel, that showed very nicely on histology that particular split at the dermo-epidermal junction that was still present up to 5 days on biopsy, which means that this delivery of cosmeceuticals post-1940 isn't just immediately after treatment, but for a few days after the treatment, there is still enhanced delivery. And this is a complete game changer. So an example, if you're treating things such as superficial epidermal melasma, where I like to combine the non-ablative fractional laser 1940 with topical tranexamic acid, the patient then can continue to use that twice a day for the next few days with enhanced absorption and better efficacy. But the same can be applied for any of the other cosmeceuticals. So the initial study that was done showed these microscopic channels that will enhance the delivery of molecules. And then when you look at this particular triple antioxidant treatment, post-treatment, you have 17 times higher absorption. Now, what does that mean? That means you put a serum on the skin, chances are some of it is going to be absorbed. Most of it probably is not going to be absorbed because we still have this robust barrier, the skin barrier. But if we just pre-treat the skin with a 1940, we then have a much better enhanced uptake and delivery of the cosmeceuticals, plus the effects of the 1940. So this is why I said 1 + 1 = 3 and not 2. Now, in this particular video, this was a patient who immediately after the non-ablative fractional laser 1940, I'm just trying to get this video to work. You can see the enhanced absorption of the cosmeceutical when it's applied immediately after the 1940. I'm not sure, can you see that? Right. Okay, so this is an example of a patient who had the combination treatment. You can see improvement at multiple levels, the clarity of the skin, the radiance, a bit of firmness, and the patient's absolutely delighted with the treatment. So this is an example where the 1940 is being combined with cosmeceuticals and we have a synergistic effect, which means very happy patients. This is another close-up view of a patient who again had the 1940 with cosmeceuticals, and again you can see an improvement in the firmness, quality of the skin, but also in some of the minor pigmentation and the blemishes, and that is because of the enhanced absorption and delivery of the cosmeceutical through the 1940. In this case also, where you can see photo damaged skin, it's almost like the skin is hungry for topical vitamin C and antioxidants. Now that depends per country what is available or what is not available. I like to combine the topical vitamin C with topical glutathione for this particular case of these particular cases of photo damage. I'm talking about topical glutathione as a cosmeceutical, but that works beautifully and very well in combination with the 1940. And you can see here cases when you start getting these complex cases of higher skin types and a mixture of melasma with a bit of rosacea, so just low density, low fluence with a non-ablative fractional laser 1940 and tranexamic acid. And tranexamic acid, of course, will also help with the redness of the rosacea because it targets the vascular component, but you can see very beautiful, nice clearance of both and smoothening and softening of the skin, which in this case we'll advise patients to have just regular maintenance sessions once every 6 months. Now you can change the recipe, and if she comes back and the skin is very clear from the melasma, I might increase the topical vitamin C or other antioxidants. But this is the beauty of having the 1940 is that you can then combine with the right cosmeceuticals that you want. Another case of a mixed race patients, typically patients with very challenging type of pigmentation, but you can see very clearly, so beautifully, the clearance of the pigments and smoothing of the skin. Could I have achieved it with the 1940 alone? Possibly, but definitely for sure by combining the 1940 with the cosmeceuticals, I pretty much can guarantee the good results. So for me, it's been a complete game changer. There's no reason why I would just use the 1940 alone. I always combine the 1940 with a cosmeceutical of choice. Once again, that choice of the cosmeceutical will depend on what I'm treating, whether it's pigmentation, melasma, photo damage, or just healthy skin. There are a number of cosmeceutical agents that we like to use. Also, this is a biopsy-proven ochronosis and a very challenging case. Of course, in this case, you'll have to do some multiple treatments, but it allows us to improve on the quality of skin, but also deliver some of the cosmeceuticals that we want. And we're getting there with clearing her stubborn pigmentation. Another case, and I'm on purpose showing higher skin types because these are challenging cases. It's easier to treat lighter skin types, but it's tougher to treat higher skin types. But this is all testimony to what this unique handpiece can do. Another case of just clearer complexion of skin by combining the 1940 with topical cosmeceuticals. Another case just a single treatment again, where you can just see things are just smoother and cleaner and nicer. And just like my colleague, Dr. Patel said, clearer skin, smoother skin is more beautiful skin, and that reflects positively on the patients. In this case, chronic photo damage, the 1940 with cosmeceuticals, and we're getting there. It can also be, of course, not just limited to the face. So the décolleté, the hands, this is another case of combining the 1940 and cosmeceuticals. Another case of photo damage. This is an interesting case of a hypopigmented scar. One of the things that I noticed is that when we use the non-ablative fractional laser 1940 wavelength, is that the colors of the scars improve. So when they are hypopigmented scars, they tend to regain color slowly, and hyperpigmented scars become less pigmented. But knowing the fact that we have these cracks and the channels that will allow us to enhance the cosmeceutical delivery, in this case, I combine the 1940 with prostaglandin analogs. Prostaglandin analogs are drops that are used to enhance eyelash growth, but they are also very melanogenic because they stimulate melanogenesis. So in this case, I treat with a 1940, followed immediately by application of a few drops of prostaglandin, and then give the prostaglandin drops to the patient, and I instruct the patient to use the drops twice a day for a week. And you can see very nicely repigmentation and blending of the scar. This is another patient from Ukraine who came, who had a very linear white scar, and you can see that is now starting to blend in and improve by the combination of the 1940 and prostaglandin analog. This is a patient of mine who, as a child, her parents chose to have a full skin graft for her congenital melanocytic nevus. She came to me looking like that. She just wanted some improvement, and this is what the 1940 can do. It can really transform lives and change lives. This meant a lot of confidence for her. She's much happier. She says she needs less makeup, less time to apply makeup, less amount of makeup, but overall, she feels much more confident. And this is just a combination of some 1940 with regenerative medicine topicals for enhanced delivery and blending in of these scars. This is another case where you can clearly see post-acne erythemas and post-inflammatory hyperpigmentation. And by just using the 1940 with the right cosmeceuticals, you can see very nice clearance of both the red and the brown. And now we can then move on to the other handpiece, which is the 1550, and target the scars. So, and this is the beauty of having the Nautilus platform, because you can have both wavelengths, and often we will start with one and then move to the other handpiece. So many of my patients who have the 1940 say that they really love the skin and how glowy and smooth and nice that is. And that is partly physics, because when you have a smooth surface, you have a homogeneous specular light reflection. But when you have a rough surface, you have diffuse light reflection. So if you look at these two images, both of them have a mountain, both of them have water, but one of them is prettier than the other. And that has to do with the smooth water surface reflecting the light in a specular homogeneous way. The same applies to these rocks. They're made up of exactly the same collagen, if we talk about collagen. And this is exactly what happens in the skin when we're using the 1940, and we get that smoothening of the surface of the skin, and therefore the light reflects evenly. That reflects very positively on how patients are being perceived. And this has been published in scientific journals, that beautiful skin is radiant skin. When you have good facial radiant skin, you are perceived as more beautiful in terms of beautiful skin. And this is exactly what our patients want. And this is why, in my opinion, the 1940 handpiece is a must in every clinic, and it's my right hand together with the V-beam and the Nautilus. So with that, I hope I managed to convince you that if you have the 1940, which all of us should have really, please do combine that with cosmeceuticals, because we have enhanced delivery, and 1 + 1 will equal 3. So with that, I'd like to thank you all for listening, and we'll hand over back to you, Dr. Konika.
Thank you. But before we move on, just a couple of questions for you. I know that you're using the topical bimatoprost in hypopigmented scars. How have you seen that work in other types of lightening or issues with hypopigmentation disorders? Do you know of anything?
Yes. Yes, so I have also used it post laser hypopigmentation on some of the patients who were tanned, who were treated on a 755 nanometer and developed the initial crusting, and then after the crusting had developed some hypopigmentation, have also used it in that context with good repigmentation. So in these two contexts, I haven't used it in the context of vitiligo, because for vitiligo we have other established treatments that we will go down that route. But for hypopigmented scars and hypopigmentation post superficial laser thermal injuries, particularly when the patient is tanned using the lower wavelengths, it works well in that case as well.
Thank you. And for Dr. Cordula, your combination of E-beam and frax and PDT is wonderful. How often do you repeat that for the patient? Do you have a retreatment regimen? Oh, we're just on mute. I think we need to, yeah, there we go.
Yes. Sorry, we don't have a standard. I would say this depends on the stage of the actinic keratosis. So patients do not necessarily have to repeat PDTs. What we do try to repeat on a regular basis is the 1940. Yeah, so 1940, as we heard from you guys already, is, in my opinion, the best repairing technology, of actinic damage, and this is going to prolong the intervals between PDTs that are needed. This is at least what what my impression is at the clinic. So we have to make some studies to really prove that, but this is my hypothesis. Yeah.
Thank you. And now we're going to turn the microphone over to Dr. Dirmach from Italy, who's going to talk to us about optimizing treatments with EBD, especially focusing on applications of EBD in acne and scarring and some other very interesting conditions. Dr. Dirmach.
Thank you very much, and thank you all for your participation. I'm so glad to be part of this webinar because all my team and me, we all use energy-based devices in our everyday dermatological medical practice. So here I bring 4 completely different situations that we normally resolve with energy-based with lasers. So let's begin easily with very light residual erythema post-inflammatory acne with some very light scarring. And basically this is not the problem, but today with this young generation that don't want to have any kind of problem on the face and they want immediate solutions. In this case, an example, we treated with only one single session, and as you can see, resolved the problem. The treatment was the combination of lasers that we normally use every time that we have to treat some light erythema with, or we have to treat some diffuse redness, like in the first stadium of rosacea, or an example, erythema fisso post CO2 laser. So basically, first thing that we do is one pass with very light settings with pulse dye laser. Then immediately after that, with Nd:YAG in microsecond modality with high repetition rate. And the goal here is with pulse dye laser to sensibilize these small, tiny, invisible vessels and then coagulate them with Nd:YAG, because with this modality, we reach the high temperatures, 41, 42 degrees in only 2 or 3 passes. And then immediately after that, we go with non-ablative fractional 90-40. in this other case, very similar to first one with some active papulopustular acne. Normally here we use the same protocol, but in this case we change a little bit. We did 2 passes with pulse dye laser. First one was with this 7 millimeters 10 joules 10 milliseconds on a single lesions using the stacking modality, which means 2 shots immediately one after the other. And then we did the second pass with, on all area with pulse dye laser, changing the settings, 10 millimeters, very light settings, just to reduce erythema. And then immediately after with non-ablative fractional 90-40. So from first day when we begin to use non-ablative fractional lasers together with vascular lasers in the cases of inflammatory acne, we noticed that we were stronger and we begin to obtain better results on reduction of erythema. So how come non-ablative fractional laser help us to reduce erythema? After playing with our skin analyzer, we noticed that with non-ablative fractional lasers, we obtain a strong reduction of porphyrin. So reducing strongly the porphyrin with non-ablative fractional lasers, and we all know how important are these porphyrin on in pathogenesis of inflammatory reaction of inflammatory acne. So treatment with non-ablative fractional lasers and this suppression of porphyrin could be used as a target for as a target approach for managing and improving the acne symptoms and inflammation. We noticed also that non-ablative fractional 90-40 works very well even alone on comedonic acne, as we can see here. The other case, which is for us everyday treatment, I mean, this is a typical patient from this area, phototype 4, with every kind of pigmentary damage on the skin. Those patients are quite tricky because you cannot use the aggressive lasers, you cannot use the lasers that give you inflammation because all of them have melasma. And so the protocol that we find here, and as you can see, this is a normal result in only one single session. The protocol is done with this combination. First, pulse dye laser. And in the first pass, we are using these light settings without DCD. So without DCD means that we target the melanin problems in epidermis. Then the second pass is done with pulse dye laser without changing too much settings, but putting DCD. So we begin to give some sensibilization on small underlying vessels because there is melasma, there is underlying inflammation, and there are small vessels. And then immediately after, with 1064 in microsecond modality, but with small change comparing to previous treatment. Here, we are using a repetition rate of 5 Hertz, not 10 Hertz. Because the goal here is to deliver some temperature deeper in the dermis. So we build up the temperature of the skin easily, and the goal is to achieve 41, 42 degrees and to keep this temperature for about 1 or 2 minutes. In this way, we have our coagulation of small vessels, superficial vessels, but we also have a stimuli on fibroblasts deeper in the dermis. And then after that, non-ablative fractional 90-40 that we use also, as Firas said, because for delivery of tranexamic acid that we use in all these treatments for 10-15 days after the treatment. And then we have this important case of Gerling syndrome. the patient with Gorlin syndrome. This is a patient with hundreds of basal cell carcinomas on her body. And she's a perfect patient for biologic therapy, but she cannot assume that therapy. So we have to find some alternative and treatment. And looking on PubMed, we have lots of publications that are talking about the non-vascular uses of pulse dye laser. I believe that this work is maybe the most complete one, and maybe whoever has or work with pulse dye laser should keep this publication on it, because every single treatment that we can do with pulse dye laser, and there is really lots of them, are written inside. This publication here shows how more than almost 50% of non-vascular treatments are based on basal cell carcinomas. And this work here give us also the parameter, the settings that we can use on treatment of basal cell carcinomas. Now, this is our patient. And of course, you understand, here we can see, I mean, 2 surgeries, but there is no sense to do any surgery here. And this is the patient after, I believe, 5 or 6 sessions. Consider that in every session, I mean, every single lesion here is treated only once. Because we treat different areas for every session, because to treat all body in one session is really something too strong. And as you can see, results are great. Now, from day when we did these pictures, we did other 2 sessions, and we begin to treat with small residual lesions around the body. And at this point, and in this moment, she's really clean. And important thing here is just to show you how nice and how good is the healing after pulse dye laser, because we shouldn't forget the capacity of pulse dye laser on controlling of wound healing process. After with this patient, we begin to have some conclusions. So important points here are the end point. Here we are talking about this white purpura. This is really strong, excessive, I should say excessive purpura. I believe that there is no other treatment that requests this kind of purpura, but here we need it. And then the important thing is when we treat BCC, we have to keep our handpiece 4 millimeters, at least 4 millimeters outside the lesion. The same conclusions has Nori in some of his publications, and he described how using these strong settings, we have completely 100% clearing of the lesions up to 1.5 millimeters of depth. On 2 millimeters, we begin to lose 20%. So it is important to use these strong settings, and we are sure up to 1.5 millimeters. And so this means that for these treatments, for this treatment are suitable the superficial basal cell carcinomas, and it doesn't matter how big they are, or we can treat the other types of basal cell carcinomas, but only if they are really small. I mean, if we clinically notice that they are not deeper than 1.5. Of course, this patient has the lesions which are nodular and ulcerative basal cell carcinomas. So in those cases, we use Nd:YAG treatment with these parameters here. Of course, the healing, the wound healing process and the scars are not the same, because after pulse dye laser, we don't have any kind of scarring. But after Nd:YAG, because he's much deeper, we have some scarring. And the last patient here, the last case here, it was in the beginning very tricky. I should say he has a tricky story, because he began with this clinical diagnosis for lichen sclerosus. Then the colleague did the biopsy, and the pathologist confirmed the lichen sclerosus. But he didn't respond at all on a clobazole, on the potent steroid, and he didn't respond on tacrolimus locally. So in my opinion, when I saw the patient, and you can see here the lesion, in my opinion, this is not a lichen sclerosus, this is a lichen erosus, which sometimes do not respond. So I did one single session of pulse dye laser with these parameters you see here, and results are very good. Then we repeat the session and I didn't see the patient anymore, which means that the problem is resolved. So this is important because quite often I'm been asked by colleagues how to use pulse dye laser on mucosas. I mean, on mucosa it's the same thing. Important is, at least in my practice, I don't use the purpura treatments on mucosa. I'm using only purpura-free treatments, but it works perfectly, and there is nothing special to think of. So this pulse dye laser inflammatory capacity, where it comes from. I mean, there's lots of publications that speak about this capacity of pulse dye laser to resolve inflammation. It is coming from his photobiological effect, because pulse dye laser target oxyhemoglobin, induce endothelium damage in the small vessels, and release of platelet growth factor, which leading to erythema reduction. And the important things that we have this TGF-beta switching, and in this TGF switching, he increased the level of TGF-beta 3, which is principal immunosuppressive cytokine. So increasing it, our inflammation goes down. And I believe we finished. Yeah, thank you.
Nikolai, that's very impressive and really life-changing types of treatments. I think that what you speak about with regards to skin cancer and basal cell cancers is going to become increasingly topical with some of the new data that's coming out. And I think it will also be increasingly interesting to see how these depths might change with some of our larger spot sizes on the V-Beam Pro. So we might have some increased improvement. We just don't know yet. So wonderful information. And also for lichen, I think that the whole idea that V-Beam also, we know, works well to reduce inflammation, whether it's inflammatory acne or whether it's to improve wound healing or scars. So there's a body of work that we have yet to uncover to really unleash all the full capacity of V-Beam where it can be used in medical conditions that are inflammatory. So thank you for bringing these to all of these cases to us. And our last speaker this evening is Dr. Didac Barco from Barcelona, Spain, who's going to tell us more about reducing skin cancer risk with EBD. So very, very topical. Thanks,
Good
Didac.
evening, everyone, and thank you, Konika, for your introduction. We're going to speak about the relationship between energy-based devices and skin cancer, and we're going to surf through this topic answering these 4 questions. The first one is, are they harmful for the skin? Can we treat skin cancer with them? Can we prevent it? And if we do it, how we do it? So the first question arising, and if we expose mice to UVB radiation, and if we expose another group of mice to IPL radiation, we see that they have more skin cancer where when they are exposed to UVB radiation, and they do not have an increase of skin cancer when exposed to IPL. There is also a big amount of publications about the use of IPL and its safety, and there is no relationship that is published saying that the IPL increases the risk of skin cancer. So we can kind of say that energy-based devices are not harmful for the skin. And actually the next question to answer is, if we can treat skin cancer with energy-based devices. The summary of the answer is yes. The first studies showed that vascular and non-ablative lasers showed a decent basal cell carcinoma clearance, but they needed a huge amount of sessions. And these authors recommend using ablative lasers, especially combined with PDT, to treat low-risk basal cell carcinomas. Nevertheless, with coming publications, other authors tended to use different devices to treat higher risk basal cell carcinomas. And the last publication regarding this topic is using the pulse dye laser on high risk basal cell carcinomas and checking if they were clear after these sessions using multiple and sequenced biopsies. And 4 of 6 cases were completely clear. So the current recommendation when you have high-risk basal cell carcinomas and you cannot do Mohs surgery, the current recommendation is using PDL laser for this type of skin cancer. We also have quite evidence using intense pulse light combined with PDT, and the complete clearance of non-melanoma skin cancer is up to 90% of the patients. So the answer to the can we treat skin cancer with EBD? The answer is yes. And can we go further and prevent skin cancer in patients of high risk? It is said that a repeated exposure to ablative laser, if we use it in a group of mice that are exposed to UVB radiation, if you use CO2 laser after that UVB radiation exposure, we see a delayed appearance of squamous cell carcinoma. So it seems that the CO2 laser delays the appearance of skin cancer even after UVB exposure. And the reduction of already active actinic keratosis in human beings we can achieve with a single exposure of fractional CO2 laser, a 62% reduction of this number of actinic keratosis. So we're doing prevention of a squamous cell carcinoma. And not only CO2 laser is useful, but we can also use the alexandrite long pulse laser if the actinic keratosis are pigmented. And we can also use a combination of IPL plus PDT to treat actinic keratosis, and see here that just using IPL with no PDT in a single session, you can reach a clearance of more than half of the actinic keratosis in patients just using IPL itself. Let's talk about non-ablative fractional laser treatment. If we treat patients that already had any squamous cell carcinoma in high-risk areas like scalp and face, and we do different sessions of non-ablative fractional laser, and we compare it to a group of patients with previous skin cancer, we see that the ones that are treated with non-ablative fractional laser, they are going to develop less number of squamous cell carcinomas. So we can say that using non-ablative fractional laser in high-risk patients, we can prevent skin cancer in them. We can use it all alone by itself, or we can combine it with topical tretinoin, and we're going to even increase more the effectiveness of that prevention. So it seems that we can prevent skin cancer with IPL, ablative, and non-ablative fractional lasers, whether if they're combined with PDT or they are used alone. And how do energy-based devices act on preventing skin cancer? Konika already said some concepts behind it. The most important thing known today is that they tend to remove the senescent fibroblast and normalize the response of the keratinocytes after UVB exposure. They tend to make the P53 expression go down, and they tend also to make medicines and drugs, or they tend to do cells more prone to absorb medicines, and they also improve the structure of the epidermis of endermis. So as a conclusion, we can say that lasers and IPL seem not to be harmful for skin, but rather tools for treating and preventing precancers and cancers by mechanisms that still need to be elucidated. Thank you so much.
That was a fantastic summary of the science, really, really rich to go back and understand where we are so far with these EBD devices, and then subsequently how we can move things forward. So it's a very, very exciting space, and so wonderful to be able to use these tools for, of course, aesthetic outcomes. That's a lovely side effect that we're getting with some of these medical treatments as well. So I want to thank our panel this evening for giving us such a important set of topics and many, many pearls that can be useful directly. We have just a couple more questions before we wrap up that I want to go ahead and ask. There's a question for Dr. Cordula. Cordula, do you think there's any benefit to treating the skin or AKs post-excision? So once it's excised, is there any benefit to treating over that area?
Oh, yes, of course. Yeah, because we know that there's the effect of field cancerization. So we usually have affected cells besides the excision zone. So that's why I would recommend to do a 1940, for instance, to treat that area.
That's very interesting. And another question for Dr. Firaz. Can you tell us about maintenance regimens for your patients?
Yes, and I think this is a very important question, because what often happens is the patients will be wowed with the results for the 1940. They really see the results and like it. And then the next question is, how long is this going to last? And in reality, well, nothing is eternal, so you will need maintenance treatments. As a general rule, I say 6 months. However, that really depends on what we are treating. Some patients would want a bit more frequent treatments, so that can be done every 3 months. But as a general rule, I tend to do 2 to 3 sessions if it's for rejuvenation, plus the cosmeceuticals, and then typically the maintenance is around 6 months.
One of the things that we noticed when we did the epigenetic study is we did a series of 3 treatments, and these are patients who had not been having treatment. So they're not patients that had already been on a regimen of annual treatment. So that may skew the ultimate answer. But what we found was that after one single session, we had some priming of the pump, so to speak. We had some improvement in the DNA methylation, or some changes in the DNA methylation, but we didn't notice further changes until we had subsequent treatments. So that even though we may see a very nice benefit after one session, on a cellular level, it may be beneficial for us to do a series of treatments, at least initially, in patients who have not had previous treatments. Now, the question remains is, once these patients have had this series, then how often should we be maintaining? And we saw our DNA methylation effects lasting up to 6 months, but that didn't occur across the board. So it's just an interesting introduction to this whole field of, in any individual patient, when is that ideal maintenance therapy? And it could be 3 months, it could be 6 months, it could be annual. But thank you for the question. And one more question for Dr. Barco. Does PDL reduce blood supply to the lesions? Is that how the mechanism works?
Yeah, this is one of the mechanisms behind the PDL and the treatment for basal cell carcinomas, for example. So the first one would be that, constriction of the vessels. So they feed less the lesion. But the second one, and which is actually thought to be the most important one, is that we use chromophore, hemoglobin in this case, to produce a tremendous inflammation, as Dr. Nicola has shown in the pictures, to induce a necrosis of the basal cell carcinoma cells, right? So yes, we have vasoconstriction, but we also have necrosis because of the inflammation caused by the laser.
Thank you. And one final question, I think, to the panel in general, if anybody is aware of any studies that are done with regards to the question is, are we delaying diagnosis of non-keratinocyte cancers as a result of treatment?
Not aware of non-keratinocytes.
No.
I think that's difficult.
As far as I'm concerned, I mean, that there is no data regarding that, so I wouldn't say so.
One of the things
if you'd like to think about it, I mean, things like solar lentigos, you know, there's always a very, very small risk that they may progress. So by using the treatment and, you know, reducing the overall photo damage and reducing the number of lentigos, you know, mathematically speaking, you may reduce then the risk of non-keratinocyte tumors, but I'm not aware of any publication really related to that.
Thank you. Well, that's our set of questions for today. Lots of interesting food for thought, and I think it's going to be an exciting few years because as we have improvements in technology, we can get even better with this. But I think what we're really going to do is get better clinically, really understanding how we can drive some of our tools that are existing. Thank you all for spending time with us, and thank you to our excellent and esteemed panel for sharing your knowledge so openly. On behalf of the team at Candela, please join us next time.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.